Welcome back to The Explainer. Today, we are bringing some serious high energy to a topic that is literally the absolute backbone of healthcare revenue and legal safety. We're talking about evaluation and management, or E&M coding. We're going to demystify these incredibly complex medical coding guidelines, break down the 2023 updates, and give you the exact structural knowledge you need to totally safeguard your practice. If you have ever felt completely overwhelmed staring at those CPT manuals, trust me, you are in the exact right place.
Okay, let's dive right into this, because the stakes here, they literally couldn't be higher. Seriously, what actually happens when a single medical coding error triggers a federal audit? We are not just talking about a mildly annoying rejected claim or a slight delay in getting paid. No way. We're talking about severe financial penalties, intense legal scrutiny, and the potential disruption of your entire medical practice. Accurate coding isn't just some boring, bureaucratic hurdle, it is the vital shield that protects both your providers and your facility.
So here is our roadmap for today. First, we'll cover E&M coding basics. Next, we'll look at office versus facility settings, followed by medical decision-making explained. Then, we'll tackle prolonged care and shared visits. And finally, we'll wrap up with coding compliance and audits.
Let's kick things off with Section 1, Decoding E&M Coding Basics, Establishing the Patient.
Accurate coding always starts at the very beginning of the patient encounter. If you get the starting line wrong, the entire claim just completely falls apart. The whole foundation of office visits revolves around this really rigid 3-year rule. A patient is only considered established if they've received professional, face-to-face services from a provider in the exact same specialty and subspecialty within the same group practice in the past 3 years. Now, there is an incredibly important caveat here that trips people up. When advanced practice nurses and PAs are working with physicians, they are considered to be in the exact same specialty and subspecialty as the physician they work with. So if a patient saw your NPA a year ago, they are automatically an established patient when they see the physician today.
Right, so once we know who the patient actually is, we need to understand how the billing splits. Both the physician and the facility can absolutely bill for an E&M service on the exact same day, but they do it under completely separate rules and payment systems. The physician bills for the professional component, so that's their cognitive effort and decision-making services. Meanwhile, the facility bills for the technical component, which covers all the overhead, the nursing staff, the equipment, the room itself. It's basically 2 parallel tracks happening at the exact same time. Moving right along to Section 2, Office versus Facility Settings, where care happens. Now, what's really interesting about this is how the physical location of the patient completely rewrites the coding rulebook. Think of this as a mini-narrative. Imagine a patient arriving at the hospital with a severe concussion. They start in Step 1, the emergency department. This is an organized facility for 24/7 unscheduled episodic care. The ED physician evaluates them, but isn't quite sure if they're safe to go home just yet. So the patient moves to Step 2, observation status. Here they're being monitored, typically for less than 48 hours, but they haven't been formally admitted. Now, if the patient's condition worsens, the physician formally writes an order, bringing us to Step 3, inpatient hospital care. And guys, each single step here requires entirely different CPT code sets.
So if that patient is formally admitted as an inpatient, we use initial hospital care codes. That's 99221 through 99223. This is reported only once per admission by the admitting physician. Crucially, any other services performed by that specific provider on the same date, like the earlier office visit or observation care we just talked about, are entirely bundled into this initial code. Then, from the very next day forward, you switch over to subsequent hospital care codes to handle all the daily rounding.
Let's get into Section 3, Medical Decision-Making Explained, the core logic.
Medical decision-making, or MDM, is basically the highly technical brain of the entire EM coding process. It completely strips away all that old bean counting of history and physical exams. Looking at this master table, you'll see 4 levels: straightforward, low, moderate, and high. These levels are driven by 3 specific elements: the complexity of problems addressed, the amount of data reviewed, and the risk of complications. Now here is the secret sauce. To qualify for a particular level of MDM, you absolutely do not need to hit all 3. You only need to meet or exceed 2 of the 3 elements. For instance, if you have a patient with 1 acute illness with systemic symptoms, plus a moderate risk from prescription management, you just hit the threshold for moderate MDM, completely regardless of the data you reviewed.
But we really need to look closer at that tricky middle column, data reviewed and analyzed. What does that actually mean in the real world? Well, it breaks down into 3 categories. First, reviewing or ordering tests and documents. And remember, each unique test or document contributes to your required threshold. Second is the independent interpretation of tests. And third is a direct interactive discussion of management or test interpretation with an external provider.
Let's zero in on Category 2 for a second, independent interpretation. This is a fantastic area to capture complexity that often gets missed. Imagine an ED provider who orders a chest X-ray. Instead of just sitting around waiting, they review the images themselves and make an interpretation right there on the spot that impacts the patient's immediate care. Even though radiology is going to provide a formal, separately billed overread later on, the ED provider's independent interpretation counts toward their MDM for the E&M visit. No formal report required, just clear documentation in the note.
All right, on to Section 4, prolonged care and shared visits, team-based billing.
And this brilliantly illustrates a major pain point. Modern healthcare is a massive team effort, but sharing care is a frequent area of confusion and a huge audit risk. The distinction we have to make here is absolutely critical. On the left side, we see a complete transfer of care. That's where one physician hands the patient off to another entirely. But on the right, we see a split or shared visit. This is a collaborative loop where a physician and a non-physician practitioner, an NPP, are managing the patient together during the exact same encounter. Now, when you're doing a split or shared visit in a facility setting, the rules are incredibly strict. The service is shared between a physician and an NPP, right? But who actually gets to bill for it? It must be billed under the National Provider Identifier of the provider who spends greater than 50% of the total time. You literally cannot just automatically bill it under the physician anymore to get that higher reimbursement rate if they didn't do the majority of the work. And to prove it, both providers must explicitly document their specific contributions in the medical record. No exceptions. Which brings us to our final act, Section 5, Coding Compliance and Audits, the stakes. So why does all of this meticulous detail actually matter? Well, it matters because of these top 3 audit red flags that auditors are constantly hunting for. First is upcoding. That's billing a Level 5 visit, a 99215, when your MDM only supports a Level 3. Second is unbundling, billing separately for a procedure and an EM visit without a modifier when they really should just be combined. And third is clone documentation. The notorious copy-paste. Pulling forward prior notes for a chronic condition without actually updating the patient's current status for today. So the crucial point is this. Your documentation must always, without fail, reflect the current medical necessity of today's specific visit.
Because if it doesn't, the consequences are genuinely severe. The Office of Inspector General and the Department of Justice, they do not look at deliberate overbilling as just a little oopsie. It can trigger False Claims Act violations, massive civil penalties, and crippling payer audits that can look back years and years into your practice's history.
So, that leaves us with one final, absolutely critical question to ask yourself today. In the face of ever-evolving CPT guidelines, is your practice truly protected from the devastating consequences of a simple EM coding oversight? Knowledge and precise, accurate documentation are literally your only armor. Thank you so much for joining me to master these guidelines. Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.